pharmacology, where we continue to look at drugs affecting the blood, but this time we're interested in looking at drugs that help to lower lipid levels in the blood. And we will look at the statins, first of all for their very important mechanism of action at inhibiting the enzyme hydroxymethyl glutaryl coenzyme A reductase. So this is a rate-limiting step in the production of cholesterol, and this is the enzyme very important in that particular pathway. We'll see that statins have their indications for lowering lipids. There are other disorders and various reasons why statins could not be prescribed. So we'll look at the role of fibrates, bile acid binding resins, sequestrants, and a vitamin, but taken as a medication and in quite large doses, nicotinic acid, and we'll look at the limitations of each of these lipid-lowering drugs. Your research this time, you'll need to go on and have a look in some detail at coronary heart disease. If you have already passed your pathology and clinical sciences subject, if you could go back and review how the heart and the nutrition for the heart is a balance between oxygen demand and oxygen supply, and that ischemic heart disease occurs wherever there is an imbalance between the demand and the supply of oxygen to the myocardial tissues. The demand of the cardiac muscle for oxygen is largely determined by heart rate, but also contractility and tension in the left ventricle. Myocardial oxygen supply is determined by the coronary blood flow and arterial oxygen content. We're going to have a look at some disorders where coronary blood flow is impeded. In various types of ischemic heart disease, you get this imbalance between supply and demand of oxygen to the heart muscles. It's seen in stable angina, it's seen in unstable angina, Prince-Mettels angina, and silent myocardial ischemia. It's also associated with acute coronary insufficiency, but most importantly, myocardial infarction. And we will see that stable angina can progress to become unstable angina, and unstable angina is unstable because there is a greater risk of an MI, a myocardial infarct. In your clientele, angina will be the most frequently encountered symptom of ischemic heart disease, and you'll be working to improve the quality of lifestyle and the outcomes for these people. Some other names for ischemic heart disease: IHD, could be called coronary heart disease because we see its supply via those coronary blood vessels that is limited. So here there's been a build-up of a fatty substance in the coronary arteries. Over time they will clog with these fatty deposits and you'll get a plaque that's called an atheroma, and it leads to a hardening of those coronary arteries, a term which is called atherosclerosis. In addition to all of the lifestyle changes that we have talked about as being critical at every point, the person may need to also go on lipid-lowering drugs to slow down the development of those atheromas. Also, if we can get a lesion that has already developed to regress because there is less and less fatty substance being deposited in those coronary vessels, this will, by the use of these lipid-lowering drugs, give a better outcome for a person with an existing ischemic process, but even for people with a pre-existing coronary heart disease, there'll be secondary prevention of any further sequelae and complications. There's also evidence of primary prevention of coronary heart disease in patients where there's no pre-existing condition but where there is a strong likelihood for that particular person, strong risk factors. Thereby all of these people, those with pre-existing coronary heart disease, those without pre-existing heart disease but with strong risk factors, there will be a greatly reduced incidence of cardiac mortality and also reduced morbidity and burden on our hospital system with these lipid-lowering drugs. But when a person has a hyperlipidemia, high levels of lipids in their blood, those lipids are generally cholesterol carried in low-density lipoproteins and also in high-density lipoproteins. The person can do various lifestyle changes to try and reduce those lipid levels, reducing stress and smoking, reducing alcohol intake. For those people who are obese, modifying their diet, reducing the level of fat intake and weight reduction, increased exercise, all of these lifestyle changes, these non-drug methods can help to control the levels of LDL, that's that low density lipoprotein cholesterol, and to raise the high density lipoprotein cholesterol that returns that cholesterol back to the liver for processing as bile salts and final excretion. That is, excretion allowing for that enterohepatic recycling. For some people though, these non-drug methods and natural methods of control of their lipid levels may not be working, and they will need Western pharmacy in these cases of hyperlipidemia. And we'll see that there are 4 different classes of drugs appropriate, some more appropriate than others for hyperlipidemia conditions. And we'll look at statins, those HMG coenzyme A reductase A inhibitors, fibrates, bile acid binding resins, also known as bile acid sequestrants, and as we said, nicotinic acid, a vitamin but taken in very large amounts. The statins partially block the endogenous synthesis of cholesterol by blocking that key enzyme, hydroxymethyl glutaryl coenzyme A reductase. They're called the statin drugs because they lead to a static level of LDL cholesterol. They also cause liver cells to upregulate the number of receptors for LDL, so the LDL will dock more regularly with the liver and will be clearing their cholesterol from the blood. In addition, VLDLs are upregulated and are continually being cleared from the plasma by the liver as well, and this will improve the person's lipid profile. A couple of examples: atorvastatin and rosuvastatin. You begin to see why they're called the statin drugs. They all have this common ending, enabling you to work out their mechanism of action, that they are these HMG coenzyme A reductase inhibitors. By the taking of these statin drugs, there will be slower progression of atherosclerosis, slower progression to angina, or perhaps for angina to progress further to a myocardial infarct. So there'll be much less morbidity and mortality from heart disease. It would be hoped that they'd have a good action on high-density lipoprotein, the lipoprotein particles that deliver cholesterol back to the liver for processing, and have been shown to cause regression of atheromas. They only have a very modest effect on HDL cholesterol. This doesn't limit their use because they have such a good action on VLDL, very low density lipoproteins, VLDL. They don't have a great deal of effect on triglyceride levels, only modest reductions there. However, there are certain statins, atorvastatin and rosuvastatin being two examples, where you do get some effect on triglycerides. As with any medication, the statins have their adverse effects. Of course, they are taken orally, so they will have gastrointestinal adverse effects, but these are rare at the therapeutic doses, and even rarer are hepatotoxicity, muscle pain, myopathy, and rhabdomyolysis, though it is a very serious adverse effect. So in rhabdomyolysis, the muscle tissue is splitting, lysing. It is at the level of the proteins denaturing, and that this rhabdomyolysis occurs. So we'll see with the bile acid sequestrants, they interrupt that natural enterohepatic recycling of cholesterol, always causing the cholesterol and those bile salts to not be reabsorbed, so that they're destined for excretion in the feces. In this way, you clear more cholesterol from the plasma. But like statins, there's changes in receptor levels as well. You get upregulation of hepatic LDL receptors, once again helping to contribute to the clearance of cholesterol from the plasma. Further, more and more cholesterol will then be taken from the blood to replace those bile acids that were excreted, and so there is increased excretion of cholesterol overall. One particular bile acid binding resin, cholestyramine, is estimated would have to be taken in an average dose of about 24 grams per day. This is roughly 3 scoops of this resin. Now it has a gritty kind of a texture, but at that dose you'll achieve a decrease in LDL cholesterol, decreasing total cholesterol. There won't be much of an effect on HDL cholesterol, but if a person has such high levels of cholesterol that it leads to that continual itching in the peripheral circulation, pruritus, then these resins will contribute to reducing that pruritus. They might be used as an adjunct to the statins or as an alternative for people that couldn't take them. One of the limitations is that gritty texture. People are then less likely to take that medication, a term compliance. If taken at the therapeutic doses, it can be very expensive therapy given that it is a preventative. There is also the possibility in some people that there will be an increase in triglyceride levels. You don't absorb this resin, it stays in the gastrointestinal system. This tends to limit a lot of their adverse effects, but there may be, as we've indicated, some gastrointestinal symptoms because of their presence in the gastrointestinal tract. Fibrates, on the other hand, would not be used in conjunction with statins. Their action is at the site of lipid metabolism. They stimulate a particular enzyme, a lipoprotein lipase. This enzyme is needed for the removal of triglycerides from VLDL, and these are also carriers of cholesterol. Because you inhibit the lipolysis of these stored triglycerides in adipose tissue, you get less movement of VLDL and VLDL cholesterol. There is a reduction in the uptake of fatty acids by the liver, and you need fatty acids for the manufacture of cholesterol in the liver. So overall there will be decreased synthesis and secretion of VLDL triglycerides. there is not only that reduced triglyceride, but some reduced LDL cholesterol and total cholesterol, and once again slight effects on HDL where they raise the levels of this helpful lipoprotein carrier of cholesterol. But the therapeutic benefits vary from one agent to another, so you have to look at the type of fibrate. One particular one, clofibrate, is contraindicated in certain liver and kidney diseases, and we said that these fibrates, such as clofibrate, would not be given with the statins. There is an increased risk of that rhabdomyolysis, which we saw was quite rare with the statins, but in conjunction with the statins would be more likely. So still there is this possibility of musculoskeletal pain, the myopathy, and as with many medications, when taken orally, there will be gastrointestinal adverse effects. Nicotinic acid, when taken in very large doses of around 2 to 6 grams per day, can inhibit VLDL. These are the very low density lipoproteins, leading to somewhat of a reduction in LDL production. So the mechanism, not really known, but thought to be the inhibition of fatty acid mobilization from adipose tissue. So then there will be less fatty acids to the liver. There will also be inhibition of the production of triglycerides. So it could be useful as an adjunctive therapy for people who have hyperlipidemia, but because such high doses are needed, compliance is once again an issue. Also in Australia, formulations that are available mean that a person would be needing to take large numbers of tablets, 8 to 24 tablets, to achieve any kind of cholesterol lowering effect, and this is seen to raise so many compliance issues. Once again, with any medication, it will produce adverse effects, especially when taken at that therapeutic dose of 2 to 6 grams per day. This will manifest as flushing and itching in the skin. So in summary, you need to know about coronary heart disease, the non-lipid lowering measures, lifestyle changes, diet, amount of fatty acid intake, and so on. But if there is still a hyperlipidemia, that the statins would be used to lower cholesterol levels. We saw that there are other possibilities, bile acid binding resins that could be used in conjunction with the statins, and fibrates that would not. We saw nicotinic acid, though needed in very, very high doses, could be used as an adjunct. We saw that warfarin is an anticoagulant. It is an analogue of vitamin K, so have a look at warfarin's actions. Look for other coumarins that might be present in herbs that might interact. There were many drug interactions with warfarin where its levels could be raised or lowered, and have a look at the use of vitamin K as the antidote when there is too much anticoagulation. Also, we said look at aspirin. It will not be included in the topics for the final assessment, but we will return to aspirin again as useful as an analgesic. So the other drugs to make sure you add to your drug diary and will be accessible on the final exam, those cytoprotective agents, sucralfate plus misoprostol, the synthetic prostaglandin. Know the role of antacids, but also the potential for abuse if people are using them for longer than 8 weeks, and proton pump inhibitors and anti-H2 used in peptic ulcer, disease PUD or gastroesophageal reflux disorder, GORD, and once again used only for short-term therapy, and the proton pump inhibitors used in triple therapy with antibiotics to encourage the eradication of Helicobacter pylori, which contributes to some peptic ulcer diseases.